So if we look at 130 and 131, I think the most important take-home message that we derive from those two studies is what is the appropriate chemotherapy backbone to use with atezolizumab, and it's nab-paclitaxel. The question about PD-L1 status, I actually think the data is arguably consistent in these trials in that in the metastatic setting, somewhere between 41 and 45% of patients in these two trials express PD-L1 on their tumor. And anytime I'm asked a question about PD-L1 status, I feel it's important to emphasize that PD-L1 can be assessed multiple different ways, using different antibodies, looking at staining on different cell types, and then different compilations of how you score these to be positive or negative. And what the field knows is it's really driven by which agent it is, therefore which company and which strategy. So as an example, for atezolizumab, the Roche Genentech strategy is to use the SP142 antibody and look for PD-L1 expression on the immune cells. And again, it was consistent in these two trials. If we look at pembrolizumab, which is the Merck compound, they use a different strategy. They look at what's called a combined positivity score, where they use their own proprietary antibody, the 22C3, to look for PD-L1 expression on the tumor cells and the immune cells and come up with a score. I actually think if we're going to continue the conversation about PD-L1, we need to think about talking about the IMpassion-130 trial. And I say that because that's the trial that looked at using atezolizumab in the preoperative setting. And here we find that in the very early stage of disease, those who are getting preoperative chemo and then surgery, in fact, the PD-L1 status didn't matter, that you had an increase in response for PD-L1 positive and negative. So take-homes from 130, 131, if it's going to work, it's going to be in PD-L1 positive patients, and it should be used in combination with nab-paclitaxel.